Another positive contribution to my mental health is Dr. Peter McCullough. New evidence of gain-of-function mutation in the monkeypox virus, as well as new evidence of cardiac damage from the mRNA vaccine. As I said, Dr. McCullough, you know him, Chief Scientific Officer at the Wellness Company, cardiovascular health expert, 30 years of experience as a cardiologist and academic internist and cardiologist, speaks widely on many topics. You can follow him on X at I hope I get this right, _ McCullough MD, MC capital CULLOUGH MD, P _. And then you can find out more about Dr. McCullough at petermcculloughmd.com. Dr. McCullough, thanks for joining us.
Thank you.
So let's start with the monkeypox thing. I find that interesting what you've observed, because you and I have been through it on the bird flu. We immediately, when they started raising alarms about the bird flu, our immediate instinct was, well, the only way the bird flu could be a problem is if they've been screwing around with it. And lo and behold, we discovered in Madison, Wisconsin, they'd been doing some gain-of-function research. So there we go. Now they start making noise about monkeypox. I was going to look the data. I was trying to look up data before the show started, and I didn't find it. It's something like 12,000 cases worldwide. Now, magically, that's a pandemic, a potential pandemic, a virus of international public health interest. How is that? What have you seen? What are they talking about?
Well, let's just get the gain of function piece here. So Nick Hulsher at McCullough Foundation reported, even back in 2003, Anthony Fauci, National Allergy, Immunology, Infectious Disease Branch, they actually had projects on gain-of-function monkeypox trying to get to human-to-human transmission. Then in 2022, when we actually did see human-to-human transmission, now analyses of the genetic code have concluded it was gain-of-function mutations that allowed it. Now, the authors don't say if it's man-made or if these were natural gain-of-function mutations, but they were. So the virus had a new function, and that is it could transmit from human to human. Previously, before 2022, it didn't happen. It was always animal to man.
Oh, that's interesting. That's why we really hadn't heard of it. And it is only through really intimate contact, right? It's got to be fluid, probably the pox fluid, like many sort of. Is it a herpes virus, like many of these types of things?
No, it's considered an orthopox virus, so it's in the same class as camelpox, smallpox. But you're right; it's direct contact, and the blisters, in a sense, have to burst to have that. It's not spread through the air. It's not spread asymptomatically. And the observation, I think, was really nailed down in a paper by Thornhill and colleagues, New England Journal of Medicine, a few years ago, where once it got into human-to-human spread, it was largely in the gay and bisexual community, largely men. And, as things evolved over time, in the Thornhill paper, it was over 40% of the cases, they were actually HIV positive. Now on the CDC website, what we've amassed over the years is over 35,000 cases of monkeypox and 58 deaths. Now, of the deaths, the vast majority have advanced HIV, and it looks like untreated HIV, looking at the CD4 counts.
Okay, so that's interesting. So tell me again the total number of cases since this outbreak developed. 35,000, you say?
Yeah, 35,000 and 58 deaths. This is in the United States. Now, the vast majority of cases, it's self-limiting. They get no treatment whatsoever, and they're fine. Now, a smaller number, more serious, and there's a paper in JAMA in 2022 at UC Davis. They just, in a sense, hospitalized everybody. And they had the skin rash, some fever, and that's about it. They received tecovirimat, which is the effective antiviral, and it's available oral or IV, and they all improved and cleared up. And it was started in that study, it started on day 12. So if you start earlier, tecovirimat, very safe and effective.
Now I was reading about this, to get the tecovirimat, I think, don't you have to apply to the CDC, or is it widely available now?
My understanding is you actually have to do the testing and tecovirimat through the CDC, and that's the slow point. Now, there was a case in Dallas in 2022 of note. and it was published in the MMWR. And it was a man from Africa, and he was not gay or bisexual. So he must have gotten it through some type of animal contact there. So he travels to Atlanta, and he visits his friends in Atlanta. And then he gets on a plane, he travels to Dallas, and he visits some more friends, what have you. And somebody notices, hey, you got a rash on your hands. And by the way, with the animal contact, it's usually on the hands because you're handling an animal. And so he gets it checked out, and they said, you got monkeypox. So they end up treating him with tecovirimat, and he's fine. But the important point in this paper, Dr. Drew, is they went back and they checked every one of his contacts, who he sat next to on the plane, who he visited. And the point is, he didn't spread it to a single person. So it doesn't spread by casual contact. You can't get it by sitting next to somebody in church or on a plane or in a classroom.
And my understanding that the current so-called outbreak is in the DRC, the Democratic Republic of the Congo, I believe. And what I don't understand is why something that is only transmitted through direct contact and intimate contact, and only during a few days of the illness, right? So the pox has to be burst. 2 days later, it crusts and it's no longer contagious. So you have something that for people with this illness, let's even be generous and say that maybe the body fluids transmitted also, but it required some intimate direct contact, and only during a few days of this illness. How can why is the world even aware of this? Why does the World Health Organization put it in the same context as pandemics? What is going on here?
Well, I think the world was sensitized from 2022, where it actually did start to move across the world in this gay and bisexual community from Europe, United States, and elsewhere. And 35,000 cases got people's attention in the United States. Now that was clade 2 that we had in that 2022 outbreak.
Yes.
The clade is
clade 1 now.
The strange. Now it's clade 1. So the difference is clade 1. The Democratic Republic of the Congo is one of the poorest countries on earth. They have virtually no health care there, none. And it's moved, according to the descriptions from the WHO, it's moved into the sex trade industry there. So there are some regions where there's mining, and the miners engage in the sex trade, and that's how it's being spread. And so they have a number of cases. I think the number's about 16,000 or so, and they've had several hundred deaths. Now, here's the proviso. Only 10% are actually confirmed by testing because they don't have availability of testing. They don't have tecovirimat available, so they don't have the antiviral. And we have no information on how they died, how many had concurrent HIV, what did they die of, secondary infection or just dehydration. So I want to caution people that when you see reports like this, don't assume that several hundred deaths in the Congo would be translatable to healthcare in LA or Dallas or Atlanta.
So what do we do with all this? Caleb, I'm going to ask you to actually look for something if you can find it. I don't know if we're allowed to play it even or not. There's a Simpsons video that I think they played yesterday on. Did you see it? Did you see the Simpsons video?
No.
Where this
I can imagine.
It's from 2010, November 2010, and it's a clandestine meeting of media heads and government officials in the head of the Statue of Liberty. This guy gets dropped off by a helicopter. The helicopter gets destroyed because no one can know where they are. And they go in, and it's 2010, and they go, well, we got to get people in line here. How about an outbreak? How about a virus no one's ever heard of before? And what do we do? And they talk about exactly what happened in 2019, 2020. It's beyond. If people want to see the future, keep your eye on South Park and The Simpsons, and you will see the future. South Park, maybe 3 years ahead. Turns out Simpsons can predict 10 or 15 years ahead. Caleb, is that a possibility that we could watch it? It's at the very...
Yeah, I think I'm able to find... No, I'm actually able to find it. I'm looking for it right now. The link I have
at the very beginning. It's the very beginning of an episode. It's only about a minute and a half, but it is so chillingly accurate. It makes you... And I was watching it again this morning when I thought about the conversation, Dr. McCullough, you and I were going to have today. And I just can't help but have grave concerns about the motivations of the World Health Organization and the World Economic Forum and anybody that starts alarming the public about there it is, about viral illnesses. Here it is. Let's play it.
We're unbalanced. It's not fair.
I'd like to call to order this secret conclave of America's media empires. We're here to come up with the next phony baloney crisis to put Americans back where they belong, in dark rooms, glued to their televisions, too terrified to skip the commercials.
Well, I think...
NBC, you are here to listen and not speak. I think we should go with a good old-fashioned public health scare.
A new disease. No one's immune. It's like the summer of the shark, except instead of a shark, it's an epidemic. And instead of summer, it's all the time.
That is...
Now, I hate to be the guy who derails what everybody else loves.
He loves being that guy.
But, Janice, we do have standards. This can't be a made-up disease. The only moral thing to do is release a deadly virus into the general public.
We do have something we've been holding on to, but it hasn't been tested. Get over here, NBC.
Well, we certainly believe in testing, but
And so while The Simpsons is predicting...
I probably have to stop it there. I don't want to get copyright strike.
Fine. That's fine. That get you you get the point. And so that was 14 years, almost 15 years ago, that I don't know where I've been snoozing that I didn't understand our media. I was in the media back then. I was at CNN. In 2010, I was working for CNN. And actually, it was a little after because Jeff Zucker, who's clearly represented as the NBC guy there, had come over to CNN, and that's who I worked for. And I never knew about these meetings that he evidently attended, but he also never told me what to say or do. I had a good relationship with him. We did what we did on our show. Maybe my executive producer heard something, but I never did. Something has drastically changed. And I'm not quite sure what it is. Is it all Trump derangement? Is it now an addiction to these headlines around medical issues that nobody should be hearing about until we decide, the medical community decides it's time to alert the public? What do you think?
We clearly need analysis and discussion. I think the most disturbing thing about the recent WHO declaration, about 5 days before that, there was a call for applications for new monkeypox vaccines.
Perfect. How could it be otherwise? Well, and they do have the pox ready to go. But here's really my conundrum, and you help me with this. I want them to be having an emergency supply of available vaccines for extraordinary circumstances. And I don't mean pandemic circumstances. I mean desperate cases where we got to try something. We should have those kinds of things as options. I want, just the way I feel like there should be access to not yet proven, say, therapeutics for cancer when somebody has a terminal illness, period, they're going to go. They want to try something. I think they should be allowed to try something. We should have a supply of all kinds of things like that, including a monkeypox vaccine. But to have the World Health Organization announcing on high that they will be distributing it and then mandating it. That's the part I can't get out of my craw. I can't get out of my system. They never had the bioethical standards met to mandate anything. And yet they mandated it in 2019, 2020. And so they've shown us they'll do it, and they will do it again if somebody doesn't push back.
Boy, this has really got you wound up, Dr. Drew. I'll say this much. The Bavarian Nordic Jynneos vaccine was received by over 1 million gay and bisexual men in the United States. And it is the one featured right now. So we have more information on it. Importantly, if one has had the smallpox vaccine, which is virtually everybody born before 1972. So I have the smallpox vaccine as an example. If we have the smallpox vaccine, we have an enhanced risk of myocarditis with the Bavarian Nordic Jynneos vaccine. I want everyone to know this. So we have to be careful there. And that it's only partially effective. Even the UC Davis study, and this is all on my Substack, Courageous Discourse Substack, where I lay this out. Even in the UC Davis study, vaccinated men still got monkeypox. Now, they were vaccinated pretty late, and there's issues of when they acquired the illness. But we should probably never vaccinate right into a highly prevalent pandemic because it's going to induce mutations. There'll be, these are non-sterilizing vaccines. It'll induce mutations. But to your point, if there was a population at risk, and it looks like here the population is HIV, and particularly untreated HIV, there could be some decisions made where it's offered, say, listen, if there's risks with everything, this could give some partial protection. But I have to think, since the deaths are not well laid out from a clinical vignette perspective, that when there are deaths, it's largely due to just dehydration, and patients would have been managed with just IV resuscitation or with secondary bacterial infection, which we would handle with antibiotics. So, if that's the case, if it's treatable, then we'd really have to ask our question, what are we vaccinating for?
Well, I would even argue there's another layer to that. But before I do, just say that the theory of the vaccines increasing mutations, of course, what Brett Weinstein was advocating, who's an evolutionary biologist. We should listen to him. Maybe he's right, maybe he's wrong. But to dismiss him as some sort of bad person for having a biological opinion is laughable. It's ridiculous. But here's, you mentioned untreated HIV. And if you've ever worked with HIV patients, particularly in the days of modern antiviral therapeutics for the triples and the duplicates and whatnot, the biggest hurdle in HIV treatment is retention. It's easy to get people on treatment, but to get them to retained and follow up and continue treatment. So my suspicion is, I would bet money on this, that the so-called untreated were really more the unsustained, unretained population. So it might be as simple as getting them back on their HIV medication so their immune system can be reinstituted, restored, and they can fight the virus effectively on their own, as everybody else does who doesn't die.
Yeah, those are all very solid points. Treatment of HIV is fundamental. Looking at the data, we can actually look at the various cell populations and get an idea of how well they're treated. Now, actually, HIV viral load is measured, and well-treated patients get to a viral load of 0 and have essentially normal, white blood cell subfractions. So they're, in a sense, immune reconstituted. So the concern is people with advanced HIV that's essentially untreated, death in the end is many times due to inanition, an aspiration pneumonia, another opportunistic infection, a malignancy.
Of course.
When I was on medical service a few years ago at a major medical center in Dallas, as a professor of medicine on standard, medicine rounding responsibilities, I had a young man with HIV, and he was in the hospital for months, and it was HIV colitis. So it was primary viral. Don't forget, HIV, the virus itself, causes primary organ syndromes. So in these cases of, quote, monkeypox deaths, we'd have to carefully look at the adjudication. I don't want anybody to think that, boy, you could sit next to somebody on a plane and get fatal monkeypox. It's just not going to happen.
No, not going to happen. And I was deep in the AIDS epidemic when it was going, and we had lots of colitis of various types. It was a primary HIV, sometimes during the acute infection with a fever. And then later you'd see isospora and cryptosporidium and one thing, just all this wild stuff. Even amoebas and things would come around. And the immune system isn't working. And the only criticism you could make, if anybody would like to criticize what Dr. McCullough and I are saying, is, well, if you reinstitute HIV therapy when someone is downstream, you can't really restore their function fully, because sometimes there are certain points you can't return from, so to speak. Yeah, but that you'd still try it. And the treatments are so good, you'd likely have a very good outcome, particularly as it comes to treating something like a monkeypox, letting your own system do that. I want to make a quick plea that I forgot to do at the beginning of the show. I want to get it out here before I go to break, which is, we've been having the worst times with YouTube. And so if you could please like our YouTube channel, share it, whatever it might be. We are being down, we are being smothered, censored, whatever you like, by YouTube. Rumble has been a wonderful partner. Twitter's been a wonderful partner.
Humiliated.
X has been a wonderful partner. But YouTube, for no reason, has continued to downregulate our, in the days when I don't know what your feelings are about Candace Owen, but obviously a very controversial person. She has no problem on YouTube. I have a problem on YouTube. Why? Because I talk to my colleagues. Because Dr. McCullough, one of the most published physicians in history, has an opinion. They don't want to hear it, and that is disgusting. So please help me with that if you can.
We just have a lock over there. We need to open up.
Lock, just open up. Okay, here's what I want to do. Yes, it's shadow banning, algorithm. There's somebody on YouTube named Algorithm saying we're being shadow banned, which is exactly right. I think that was more of an X thing, but now the X is an actual platform for actual discourse. We're having no problems there. In fact, we appreciate everyone that sees us there. So I want to take a little break. And we come back, Dr. McCullough, I want to talk about viral illnesses generally. Midnight Rider 2001 is saying, I threaten the deep state. I hope not. Well, maybe I hope I do. I'm not sure. I'll have to think about that during the break. Whether I want to threaten the deep state or I don't want to be a threat to the deep state. But Dr. McCullough and I traveled at one point, and one of our travel mates, a man in his 50s, developed an acute viral syndrome. And Dr. McCullough gave some very specific recommendations. And while I heard his recommendations, I was thinking to myself, "Oh, this is going to be a disaster. We're another country. It's probably COVID. We don't have access to this and that." And that guy was not just better by the afternoon; he was well. He was cured, and it broke my brain. And so I want Dr. McCullough to review for us his ideas about treating viruses, the McCullough method, and where he's come up with it. There's a whole big topic here. Also clotting and genetic testing and all the stuff you've enlightened me about. So I want to get in that. I want to get in that whole topic after the break here. So stay with us, everybody. It's a very interesting bit of material to get into, and you won't hear it anywhere else. We'll be right back after this. Get Dr. McCullough back in here. I think you know Dr. Peter McCullough. Let me get you the specific. It's X. It's P_McCullough MD. Is that where the X? Yeah. Okay. It's on X. And I want to start with, well, let's start. I want to read a quote from Dr. Peter Hotez in just a second that I think is interesting. But before we sort of look at his challenge, which is interesting, I don't want to say wrong or alarming or anything, it's just interesting. Talk to me about your approach to viral illnesses and how things have changed, how your thinking has changed.
Well, I tell you, the pandemic really changed it for me. I didn't put much thought into it before. I've been a victim of many colds over the course of my life. And I think many are. You know, the average person gets about 4 colds a year, and some get many more. But for me, a cold almost always starts as a sore throat. So I get a sore throat for several days. And then it kind of, in a sense, it, quote, moves into the sinuses. And then there's congestion and coughing and sneezing. And then you go on from there. I've basically learned from, reading a lot of papers, then working with a lot of patients, is that the minute you have a sore throat, Dr. Drew, it turns out the virus is in the nasal passages. The virus wants to be in a warm, moist place to replicate. That's the nasal sinuses. So the sore throat is a sign that the virus is actually in the nose. And now we have over 20 studies, prospective randomized trials, that nasal sprays and gargles work for every form of a viral upper respiratory tract infection. So the principle here is, if you can knock down the virus a little bit, not let it set up camp for days, then you give a chance for mucosal immunity to the cellular and humoral-based immunity to, in a sense, handle the infection so it doesn't invade your whole body. And this was critical with COVID. So the important thing is, people have said, well, what works? Well, on my show, McCullough Report, I actually held a nasal hygiene summit. I brought all these experts on. We can start with saline. Just saline itself has a benefit. If you just use a saltwater nasal spray and gargle, people who live by the ocean, who get a lot of saline, seawater exposure, nose and mouth, that works. And then you can go from there. If dilute iodine, whether it's Lugol's iodine or Pulvin iodine, that actually kills most viruses. Xylitol, which is a natural sugar derived from corn cobs and other plants, xylitol seems to impair the viral replication, and many times these products are combined with cardiologist or with grapefruit seed extract. They also inhibit viral replication and viral attachment. Colloidal silver, a little less effective in the nose. And believe it or not, in babies, dilute baby shampoo works, just with a little bulb syringe. So virtually anything in the nose and mouth works. Gargles, we've looked at this. Scope and Listerine work just fine. But even a saltwater gargle or 50-50 with hydrogen peroxide in the throat works fine. So in order to start this at the beginning of a viral infection, you've got to spray the liquid with a spray bottle up the nose till you feel the liquid, sniff it back, and then spit it out. Sometimes it hits the soft palate and chokes. That's a good sign. Do it twice on each side. And then gargles is a 30-second gargle. Whatever you want to choose to gargle with, 30-second gargle, and then spit it out and do both of those twice and do the whole procedure every 4 hours.
I actually, I'd heard you speak about this, and I'd read some materials about it even before I heard you speak about it. And during this recent during the recent COVID outbreak here in Southern California, I saw a lot of COVID. And there was one day where I was in an elevator, and I get viral illnesses really easily. I'm like you, I get them all the time. If I'm around somebody, I get it. I was in the elevator with a COVID patient. I was in a small exam room with COVID patients. And that morning, right after seeing those patients, I started nasal lavage, and I did not get COVID. And I have been doing it ever since. Why not? At least twice a day. Because I get everything. Plus, there's outbreaks that come along without our awareness. And now you said to use a spray bottle. I do the same thing as the neti pot, where it kind of comes out the other side.
That's pretty intensive.
I do it with a spray. I do it with a spray bottle. I do it with the squeeze bottle.
Yeah. So, but those are very intense. But let me give you some literature to cite. A randomized trial by Bamforth and colleagues. It's a pretty large, prospective, double-blind, randomized, placebo-controlled trial, xylitol-based product, and the over-the-counter product would be Clear, Xlear, Clear, versus placebo. There was a 71% reduction in contracting COVID. This was better than
I fully believe that.
Yes.
Look, I get everything, and I did not get that outbreak. And my last COVID episode, I'm not boosted, and my last COVID episode was a long time ago. So I feel like my immunity should be relatively waned. But I am using the saline like crazy, and I am an Xlear advocate too. I think that's a good product.
Yeah. Well, people say, well, which one should you use? The bottom line is use anyone. I think
Anything.
the iodine-based products probably better acutely, but after a few days, they get a bit irritative. And then the xylitol-based products, I think, are more soothing. But let me put some name brands out there. Cofix RX, which is a combined xylitol, iodine, vitamin D product, very good. There's Immune Mist, which is iodine-based, betadine, iodine-based, Clear, xylitol-based. Even saline works. Scope and Listerine are fine. The one I like for gargles is actually a xylitol gargle, and that's Spry. So you can find these. You can make them on your own. Recently, I had a summer cold. I jumped at it recently. I really contracted. I reduced the duration of time greatly, but sadly, my wife got it. And I was so frustrated because I slept in different bedrooms and stuff. She got it. And so yesterday, she was starting this whole process we talked about. And so we had a bottle of Clear. All I did is put a drop of iodine in it. Now, let me give another pointer on this. Anything that burns or stings in the nose is too strong for that person. We should never have any discomfort. Dilute it down. Everything is too strong. I tell a lot of the people listening.
By the way, you need sort of plasma concentration of something. I noticed when because I got desperate one day, I didn't have access to anything, and I did it with water, and that was terribly irritating.
Yes.
So I just don't do water. Water's is not enough solute in the water to be soothing.
Right. So use saline or put a pinch of salt in it. People should not use distilled water or sterilized water. Go with saline. Saline is very comfortable. If there's any burning at all, dilute it with saline. So you can actually buy a bottle of saline at the drugstore. It's actually quite handy to have around the house.
Well, neti, I'm using. What am I using? It's in my. And they have little salt packets you put in and mix up, and that's it. It's all measured out to be appropriate for the nasal mucosa. So, okay. And then if somebody, what?
Nasal mucosa.
That's what lines your nose, is the nasal mucosa. Sorry about that. But so let's say you get the illness, which will happen sometimes. Now what is the McCullough principle?
Well, the first principle we said was using nasal sprays and gargles, getting fresh air. So do not try to stay in an enclosed space. Colds will go by quicker if you're opening up the windows. You guys live in California, get the windows open, get fresh air. And then we move into what we call the OTC bundle, the over-the-counter bundle. These are things available over-the-counter where there's an evidence-based. And let's just say it's the worst of all the respiratory infections, it's SARS-CoV-2. That includes aspirin. Aspirin has a mild beneficial effect. Vitamin C. But if vitamin C is going to be taken, I've learned from colleagues, we got to go much higher doses. So vitamin C, probably 3,000 milligrams several times a day. Vitamin D, we've learned is actually therapeutic. So we're looking at about 20,000 units of vitamin D. Some use even higher. Okay. Now, listen, we do this for a few days, not forever. But vitamin D is medicinal, therapeutic at that effect. Quercetin, a polyphenol supplement, has positive data. And one thing we learned was so interesting with SARS-CoV-2 is the antiviral effect of famotidine. Famotidine is over-the-counter Hepcid AC. We give it 4 times the usual dose, which is 80 milligrams. A large study by Mira and colleagues, University of Virginia, there were substantial reductions in serious COVID, including need for ventilation. So, and there was a 20,000 patient study. So the bottom line is we actually have a lot of things we can do over the counter. Zinc is in that group as well. I think I've hit them all before we move on to prescription drugs.
And as we get into prescription, also, I'm trying to find it right now. I just saw a report on I guess it was Pepcid. It may have been famotidine. I'm going to look around while you're telling me more about the prescription drugs. There was something else that was relatively common and a non-antiviral medicine in our mind, but works against viruses. I'm going to look around for that. Then what do you do? What else prescribed?
Well, once we get into the prescription drugs in that next level, it was always a series of choices. So I think in 2020, the go-to drug was hydroxychloroquine. As we had more data in 2021, it became ivermectin, but we took a while to figure out the dose, 0.6 milligrams per kilogram. And then once we got into 2022 and beyond, Paxlovid, a combination of nirmatrelvir and ritonavir, and then finally molnupiravir. Those were all antivirals. By the way, none of them were necessary nor sufficient to treat the illness. People have made a big deal about one drug or another. Dr. Chetty in South Africa, as well as Dr. Berentios in Central America, widely promulgated and utilized protocols with no ivermectin or hydroxy. And they got people through the illness. They featured more antihistamines, aspirin, corticosteroids. But the antivirals have a role, clearly when started early. I've used them all. I think the one that probably has the most pop to it in terms of immediate relief of symptoms is ivermectin. And again, we're talking about SARS-CoV-2 infection. Hydroxychloroquine is particularly utilitarian because it has anti-influenza effects as well. So I think that's terrific. Now, in that prescription drug bundle, we include doxycycline to cover superimposed bacterial infections, super important for influenza, and then azithromycin. Azithromycin covers superimposed bacterial infections, but with SARS-CoV-2 infection, there was about a 2% rate of patients actually having superimposed mycoplasma or chlamydial infections, chlamydial pneumonia infections. So we needed azithromycin there. Several studies show azithro probably has some antiviral effect. So that is that next layer in the McCullough protocol. If you go to petermcculloughmd.com, you want to follow along, you can see the McCullough protocol. This was the first to be published and the most widely used set of principles throughout the pandemic across the globe. And then after that, we moved into drugs to manage inflammation. That is the corticosteroids, dexamethasone used in the hospital, but doctors are more familiar with using methylprednisolone or prednisone in the office. We added montelukast or Singulair, antihistamines like cyproheptadine, colchicine, very important drug. Colchicine is an anti-inflammatory originally used in gout. There's been 39 meta-analyses of the dozens and dozens of trials of colchicine in acute COVID. There's about a 30% reduction in mortality attributed to colchicine, believe it or not. And it's always used for 30 days in the setting of SARS-CoV-2 infection. And then the last layer in the McCullough protocol was antithrombotics, and we got into blood thinners.
All right, we're going to get talking about the blood thinner thing in 1 second, but I remember now what the medication was that has shown some really substantial effect, and it's from our friend Harvey Reish, who has metformin. I don't know if you saw that study he circulated, but metformin, I was astonished.
There's some other drugs. So metformin, there's anti-androgens. The Brazilians popularized that. There was some really neat over-the-counter natural solutions. So, for instance, artemisinin, which is worm brood, had positive data. If you look up ivermectin and artemisinin, the Nobel Prize was awarded to both in the same year. Very interesting. Spirulina, which is from a green algae. There were many products that had effects there. So I talk with doctors all over the world. There were doctors in Asia. They weren't using any of the drugs we talked about. They were using some of these other natural solutions. And I asked them, how'd you come up with this? And they said, we're largely doing historically what we did during Spanish flu.
Interesting.
Yeah.
All right, here is a ex post by Professor Peter Hotez. Dangerous health disinformation not supported by published biomedical literature. All right. SARS-CoV-2 is a thromboembolic virus with strong evidence. Okay, let's just go sentence point by point. SARS-CoV-2 is a thromboembolic virus. That is factually true, and is probably perpetrated by the spike protein. We both agree on that. The spike protein is the thrombogenic thromboembolic component. Okay, with strong evidence that one of the best ways to protect your heart is to vaccinate versus COVID. Attaching key papers. So, okay. Well, let's kind of break it down. You're shaking your head no. If I'm 85 years old, maybe. But if I'm 22 years old, no. Especially in the era of Omicron. Am I saying anything wrong? I think you might take a stronger position than I do.
Well, let's look at the cardiac risk. With the infection, there was a paper from the VA by Xi et al. This is a few years ago. With the SARS-CoV-2 infection, and this is before the vaccines, there is a cardiovascular risk of the infection, and it lasts for about 6 weeks. And there's a risk of stroke and heart attack and atrial fibrillation. And the risk is nearly identical with influenza. And so the point is, in elderly people, a viral infection can trigger a cardiovascular event. Okay.
Although Dr. McCullough, I'll push back a little bit and say when I had nasty COVID in the Alpha and Delta era, and I think I told you this, I had 103 fever, I was climbing some stairs, and I took my pulse, and my pulse was 60. And I thought, this is infecting my heart. Somehow, I didn't know, none of it had been reported yet at that time, but I should not have had a pulse of 60 with 103 fever climbing stairs.
It was affecting the balance of your sympathetic and parasympathetic nervous system. Now, people have asked the question, does the SARS-CoV-2 virus directly cause myocarditis? Well, there's been autopsy studies just in the infection, no vaccine. Answer, no myocarditis. You can't find the virus in the heart. Okay. There's never been an adjudicated case of clinical myocarditis in somebody just with the infection alone. And there was a huge study by Daniels and colleagues published in JAMA, the NCAA Big Ten, where they screened athletes who had COVID, about 30% of athletes got COVID, for myocarditis. And they had EKGs, troponin, ultrasound, MRI. And they found about 36 cases that maybe were myocarditis, no hospitalizations, and no deaths. So the point is COVID-19, and now the recent Open Safely study, huge study from England, over 1 million young individuals, COVID and the vaccine, myocarditis is only caused by the vaccine, not the infection.
Well, certainly in 22-year-olds, right? I mean, how can you debate that? Now, the other thing that is being claimed is that these young males that get myocarditis have mild self-limited disease. Now, half of them in a study out of Japan had persistent myocardial dysfunction and damage at 12 months. So how can they say that? And why aren't we just saying, well, the jury is out? It looks, we're not seeing, or are we saying, I've not seen I've seen an outbreak of arrhythmias, I've seen an outbreak of myocarditis, pericarditis, but I've not seen an outbreak of cardiomyopathies yet.
Well, I am seeing them. Actually, I just finished with one. Let me say this much. The original analysis by Tracy Hogue at UC Davis, about 90% of clinically recognized vaccine myocarditis required hospitalization. So by definition, it's a serious adverse event. Now we have a paper out of Japan just recently, Takata et al. This is a stunning, huge number of vaccine myocarditis cases. The mortality rate at 62 days, Dr. Joe, 9.6%. Listen, it takes a lot to kill a healthy young man. 9.6%, I'm telling you, as a cardiologist, is a high mortality rate. So it's irresponsible to say that it's mild or it's self-limited or it's transient. You've just reviewed the data that it's not.
Yeah, I don't understand why. And again, the whole job in medicine is to use our judgment to create a proper risk reward analysis, like the risk reward. And when I look at in the Omicron era, and you've just reviewed some data on, say, 20-something-year-old men, the Omicron risk is effectively zero. And the risk of all I need to know is this, and the risk of the vaccine is non-zero. And exactly what the number is of the non-zero risk, I'm not exactly sure, but it's not zero, and it looks kind of nasty. That's enough to cause me, this is what I've been struggling with for 2 years. Why are we making college-age kids mandating vaccines in an age group where you're mandating a dangerous intervention for a zero-risk illness? I can't get my head around it.
The first fatal case of myocarditis was published by Verma and colleagues, New England Journal of Medicine, the summer of 2021. There should have been emergency meetings on this. And since that time, we've had paper after paper. Gill and colleagues at Connecticut reported boys 16 and 17 who died on days 3 and 4 after Pfizer, found dead in bed at home. This should have been all hands on deck emergency meetings. We shouldn't have had young Americans dying of the vaccine. These are autopsy-proven cases. Now, Hulsher and myself have published the first risk stratification paper. That is, what should we do to try to sort out risks of people who took the vaccine?
Well, that's what I want to get into next. And some of your sorting on that risk is around coagulopathies, around risk of clotting and that sort of thing, and the genetics around that. Talk is the best we can. It gets a little bit into the weeds here, but give people a sort of an overview of what your concerns are with that and how you approach it.
Well, let me just say at the outset, 4 studies, Schmeling, Manichi, our CDC VSafe, and even an Indian study. The people who are at risk of a vaccine problem, I think, are between 5 and 10%. So it's not everybody. I don't want everybody to panic. It's about 5 to 10%. And some of it depends on the batch that was taken. You can go on how bad is my batch and look it up. There are many batches where there are 0 side effects. You can find 0.
Is that Manicky? Is that a follow-on of Manicky's study? She was the one that originally, she's the Danish woman, right, who originally studied the batch phenomenon.
Mm-hmm.
Yeah.
So they've done this in Denmark, the Czech Republic, and Sweden now, and it's all cohesive. The other thing is... And
so is this follow-on to that, right? This is follow-on to her original study?
Yeah, and how bad is my batch is an operational database you can access, and that's actually based on our VAERS system in the United States. But the other point is the earlier shots were far more risky than the later shots. And they've probably, the lot sizes have gotten a lot bigger. Don't forget the spike protein you've pointed out is less pathogenic, and that's the spike protein produced from the vaccine. So the earlier shots far more dangerous than the later shots. Now, the number of shots matter. The number of times you've had COVID matters. That's in the first part. If you go to preprints.org and look up the Holster-McCullough risk stratification paper on my Substack, you'll see this. So we have to assess risk of what's the exposure, number of vaccines, and number of times you've gotten COVID, and they both matter. The batch matters. And then, of course, there's susceptibility factors. Someone with a family history of blood clotting, watch out. We could be at risk for a blood clot. Somebody who already has a weak heart due to heart failure, prior heart attack, watch out. I have one patient of mine who had prior bypass surgery. He had a weakened heart. He had a defibrillator, one shot of Pfizer, and he actually needed a heart transplant. He went into cardiogenic shock and nearly died. So I've seen it all as a cardiologist, but we believe is assessing the risk of number of shots in COVID, the batch, and then we actually measure the antibodies. The antibodies against the spike protein are an indirect measure of how much spike protein is still stimulating antibody production. It's a lagging indicator, but we use the extended LabCorp assay, which is the Roche Alexis system. Less than 1,000 looks like it's low risk in the literature and our clinical experience. Over 1,000, consistent with multiple exposures. Some vaccinated, Dr. Drew, over 25,000 of the arbitrary units on this assay.
So here we are, 3 years after, 4 or 5 years now after the excesses of all this, and we're still seeing remnants of it in, we have a presidential campaign that's requiring boosting in young people. We have the World Health Organization raising alarms about non-alarming infections that the public should not even know about at this point in time, until physicians decide it's appropriate to talk about how to stay safe and how to treat if you get it. We have the World Economic Forum further wanting centralization of authority and this World Health Organization treaty, so-called, that thankfully some of the states are fighting back against. I'm wondering what keeps you up at night these days. You've been through a lot through the pandemic. You've been canceled. Your academic positions have been stripped by the very people that placed you on high. It's been such an extraordinary experience and so mind-boggling and clarifying in a lot of ways, both at the same time, confusing and clarifying. What keeps you up at night? What are your thoughts these days? What have you learned? What are you worried about going forward?
I'm worried about people intellectually giving up in our field, Dr. Drew. I haven't seen a single major chief of medicine or chief of infectious disease come out and say, listen, the vaccine program has failed. It didn't stop COVID. We have safety problems. Not a single one. There's been a limited group of people who, were so moved by this. And as you point out, many sacrificed to bring the world the truth on this. But our strength, our core strength and group number has not expanded. The esprit de corps has not expanded. We haven't seen, we have two major presidential candidates that will not review pandemic response. They will not. In fact, one of the speakers at the Democratic National Convention last night was actually criticizing Trump's early response to pandemic response. I thought that was kind of interesting. But we are not seeing this broad correction. Just like when doctors castigated Ignaz Semmelweis for proposing that we wash our hands, it took 20 years before a doctor said, you know what, he was right, we should wash hands. When Rosenhill said smoking causes lung cancer, it took over 20 years before the medical community said, yeah, smoking causes lung cancer. And you know very well the opioid pandemic, it's taken a long time, again, about 20 years, for doctors to come around and say, yeah, we were part of this, terrible time in medicine, still are. So with COVID-19, we're 4 years going 5 years into this, and we're not seeing the broad correction yet.
Well, I will take your counsel on this, and the counsel is patience, and I will be patient. It's not easy to watch, not easy to live through. Two quick things, maybe three, before we wrap up. Didn't Redfield I feel like he's sort of looking at things and talking about the mistakes made. Yeah, so I'm so grateful for that. It's like, I don't care. Okay, yeah, you made mistakes. Good, everybody makes mistakes. Thank you for coming clean so we can learn from it. Yeah. So he has gone way up in my esteem. One other thing is the book. Put it up there, Caleb. Please do get the book. It reads like a mystery novel. It's written by a mystery writer, The Courage to Face COVID-19. You want to know what happened, how it happened, there's the history right there. I wonder if you want to comment on that, Peter, before I have one last question.
Yeah, well, it's a fun book to read. It takes about 2.5 hours. John Leake is a terrific writer. He's a bestseller. And I think a book like this, it just can't be written as a boring medical book. So, it kind of takes you through the journey, introduces Joe Rogan and Tucker Carlson and what happened. Even chapter 11, the title is Cuomo-sexuals, which John says is a real word about Andrew and Chris Cuomo as an example. But it tells a story about what happened and the shock about the systemic suppression of early treatment in the medical community gripped by fear, and the tragedies, and of course some victories as well. Courage to Face COVID-19. It was the only book in this genre that was banned by Amazon. It was having 5-star sales, doing great, and then last fall Amazon said, we're banning it. And John and I said, why?
Very
What's
odd.
wrong? Yeah, why? They said, well, it has offensive content. We said, where? They said, we can't tell you. So we appealed and we fought and we appealed and we fought, and some heavy hitters got involved. And after 12 days, Amazon said, I guess we're wrong. We're going to restore it.
Oh, good. Jeez. Well, that's good. Those stories I like.
Yeah, like a 12-day ban. Like, why? What did that serve?
Nothing. It's somebody's.
It
it's
was
so
to knock you off
dumb.
the charts.
It's
you were having
it's
too
so
much,
dumb.
too much.
It's so disappointing. It's just disappointing and dumb. And then the last thing is something that people have been asking on the Restream and over at the Rumble Rants. Any thoughts about Novavax? And I think you and I have talked about before. Novavax, of course, is a spike protein, but it doesn't have the same replication potential as the mRNA vaccines. Not a spike factory being created in your body.
Right. It's just the antigen-based vaccine. My analysis of this was always the safest choice. It was always the safest choice.
And Covaxin, guys. Covaxin's another one. And that's a whole viral vaccine. And again, the fact, Dr. McCullough and I have talked about this in the past. I'll just briefly touch on it. We both are completely convinced that the spike protein itself is the primary pathogenic mechanism, the thing that hurts us from the virus. And to create a vaccine directed at that spike, I understand that in an emergency, you had to find a widely available target. They picked the spike protein, but making our bodies produce the pathogenic protein, now that the risk of the virus is almost nothing, makes no sense whatsoever. If you have to have a vaccine, Novavax, Covaxin, okay, fine, let's get these other vaccines going then.
Right. Well, the principle is Novavax limits the exposure. It's 5 micrograms of the spike protein. With Pfizer and Moderna, it's unlimited production of spike protein. You can't shut it off once the vaccine is injected.
And we know that the people that don't shut it off, both by measuring the antibodies to the spike protein and the antigen of the spike protein, we know that's what's happening when people get into trouble. We just don't know why or who they would have been, which is why we can't, decide who to not give it to necessarily. All right, listen, Dr. McCullough, you've been very generous with your time, and we really appreciate your being here. It's so important to catch up with you and hear your thinking as things go along. I'm hoping that your work, your thinking, putting you in the public domain and making people think about what you're thinking about might accelerate this transition from a more reasoned evaluation of what happened during COVID from 20 years down to maybe 14 years. I will feel like I've done my job then.
Right. Thank you so much for having me.
All right. Thank you so much. You bet. We got it. Again, you can follow him at P_McCullough MD on X and Peter McCullough MD on .com.